Hello. It is my great pleasure to join the baseline wave of LASI dissemination webinar. I'm Jinkook Lee, a professor of economics at the University of Southern California and one of the PIs of the LASI. This is a fruit of my colleagues at IIPS, Harvard, and University of Southern California's significant and diligent efforts over 10 years. I'm going to briefly go over the methodology we employed in this talk. I'd like to start with the key aspects of research design, which shaped our sample and instrument. LASI is a nationally representative panel study. To enable the study of longitudinal changes and birth cohort differences, we adopted a steady-state design, not only following our sample over time, but also bringing in new age-eligible sample in every wave. So we can compare aging processes for those who were age 45 and older in 2017 and the same age group in 2021. For successful maintenance of panel study without an excessive budget, we adopted a clustered sample design. We targeted older adults aged 45 and older and their spouses regardless of their age, and this age threshold of 45 is selected to enable us to study the challenges in labor force participation well before one retires. Considering significant cross-state variations in policies, we aim to achieve not only national level representation, but also state level representation, and sampling strategy is developed accordingly. One of the key distinguishing features of LASI is its multidisciplinary nature, covering the topics ranging from demographics to health and cognition, economic and social aspects as well. We try to bring several important innovations, integrating biomarkers into social survey. Biological markers provide objective measures without self-report biases. We provide high-quality economic data, including not only consumption, but also income, asset, and debts, based on the latest advances in survey and economic literature. Finally, we used a computer-assisted personal interview for data collection, which established us real-time data monitoring and supervision. Now, let me briefly go over our sampling strategy, a multi-stage stratified area probability cluster design. As we aim to draw a sample representative of each state and union territories, we first stratify all subdistricts within each state and union territories according to geographic regions, then within each region according to subdistricts' population size, proportion of scheduled caste and tribe population, and the proportion of males in non-agricultural sector. We selected the primary sampling units from each stratum, and then from each PSU, we chose 5 secondary sampling units from each PSU. The sampling frame for these SSU were villages in rural areas and census enumeration blocks in urban wards from 2011 census. Since there is no readily available sampling frame for households in India, we carried out a mapping and household listing exercises. This means that we sent a field team to all selected SSUs and identified all households in the selected villages and census enumeration blocks. Population-wise, India is a still young country, with older population proportionately small in numbers. Therefore, in order to ensure large enough sample for older population, we oversampled those ages 65 years and older. With this oversampling, about 1/3 of our sample is ages 65 and older. We also oversampled 4 metropolitan cities to provide city-specific estimates. In determining sample size, we consider the sample required for accurate estimation of disease prevalence. The sample size of 1,000 for each state seems to be the minimum necessary sample size for reliable estimate of disease prevalence, so we targeted 1,000 age-eligible sample for the smallest states and union territories. For a state with larger populations, larger geographic spreads, and more heterogeneity in socioeconomic status, we recruited larger sample to ensure sample representation. For example, we have a sample of 4,000 for Uttar Pradesh and 2,000 for Tamil Nadu, excluding Chennai, and Chennai itself has 1,000 sample. Here you can see a diagram of our survey protocol. After mapping and listing, we randomly selected households for potential LASI interview. But without an interview, we do not know whether selected household would include anyone aged 45 years or older. Therefore, all selected households, we collected household roster information, identifying all household members' age, gender, and other basic demographic information. Here, the households with age qualifying persons are then considered as LASI household, and the household without age qualifying person were not selected for interview, but information is kept for drawing refresher sample for follow-up wave. Through cover screen interview, we also identify who is most knowledgeable about household finances so we can administer household interview. Note here, we collect household level information only once by interviewing most knowledgeable person, and the informant who answered questions on income and wealth could be, and in fact often differ from the informant who answered questions related to housing. From cover screen, we also identify spouses of all age qualifying others, and based on this information, we conduct individual interviews with all others age 45 and above and their spouses regardless of age. All individuals who were selected individual interviews were also asked to participate biomarker collection. Finally, we also conducted a separate community survey for all selected SSUs, which I will discuss next. This slide summarizes the key survey contents. For household interview, we collect information on housing characteristics. We also collect information about consumption, assets and debts, household income, and insurance holdings and coverages. For individual interview, we start with detailed demographic information, current work for those who are in the labor force, and past work for those who are no longer in labor force. Their retirement and pension, post receipts and eligibility. We administer the comprehensive health module, including both chronic and infectious diseases, functional health, cognition, health behaviors, and healthcare utilization, as well as family medical history. We collected information about family members' demographics, their interaction with visiting them, communicating with them, and the support they provide. And finally, we have experimental modules to bring innovative new contents. Each respondent was asked to answer one of these experimental modules, so you will see a quarter of respondents answered each of these 4 modules. Our rich biomarkers include anthropometrics, blood pressure and pulse, several performance measures like timed walk, grip strength, and vision test. We are currently conducting DBS assays, and once assay work is complete, we plan to release those data as well, together with the spirometry data. Finally, we collected the community level information by interviewing knowledgeable persons at the community like government personnel. collecting information about infrastructure available in the community and history of environmental shocks, and the prices of ration goods. Our instrument was developed separately for rural and urban areas, given significant differences between urban and rural areas. This diagram illustrates how we implemented the data collection supervision and how we monitor the data as they come in. Our LASI team, including collaborators at IIPS, Harvard, and USC, developed the project protocol. Then core LASI team at IIPS played a pivotal role in interviewer training and project management. Training and management were organized first at national level with the state team, and then each state team organized the fieldwork for their own state. The national level training was done in English, and then all state level training was done in local languages. Regional geriatric center support was critical in collecting health and biomarker data. One of the main advantages of conducting computer-assisted personal interview is to be able to monitor the data in real time. As the fieldwork unfolds, we asked each local team to upload the data to server regularly, at least once a week, and we were able to monitor the progress of fieldwork and examine the distribution as data come in. We diligently monitored the data, and when unusual patterns were observed, such as interview administration time took too long or too short, inconsistent, unrealistic responses were recorded, we then went back to the respondents and sorted out particular cases. For sheer magnitude and complexity of work required careful planning and implementation. We unfolded the fieldwork in 3 phases from April 2017 till November 2019, although most of data collection were done in 2017 and 2018. We achieved excellent response rates despite that it was a lengthy interview, taking about 2 hours for an individual interview, including biomarker collection, and slightly less than an hour for a household interview. So for a household with 2 eligible respondents, the entire interview would take about 5 hours. Now I invite all of you to explore our rich data. You can obtain LASI data by applying for data access at IIPS website as well as USC website shown here. This is an opportune time for aging research in India. Let's get busy. Thank you for your interest and attention.